Good afternoon. It's a pleasure for me to start with a new webinar. We're going to talk about the class 2 malocclusion, about the class 2 in contemporary orthodontic. We have different topics. The first topic is the problem of the class 2 in contemporary orthodontic. The next is the new class 2 malocclusion classification, the role of the nasolabial angle, and the nasolabial angle is for us the lighthouse that guides our treatment, the dentoalveolar maxillary class 2, the molar and incisal treatment, the mandibular class 2 treatment, the big mistake, and inside of the main problem is the mandibular class 2 treatment in contemporary orthodontic. We have different points. Do you believe in genetic or in epigenetic? The dental-alveolar pull or jumping the bite, the class 2 intermaxillary elastic or functional removal appliance, and start the treatment just in time. The first point is about the problem of the mandibular class 2. Let's be honest. What is the most popular mandibular class 2 treatment? Patient with retrognatic mandible. What is the most popular treatment? The most popular treatment is the intermaxillary class 2 elastics. Maybe 90% of the doctors in the world use the intermaxillary elastic class 2 to treat the patients. For the reason, this is a big problem because a lot of orthodontic techniques use the intermaxillary class 2 or appliance like intermaxillary class 2 to jump in the bite, to do a different connection between the maxillary and the mandible, using the just bumper, the different type of coil spring, the biela or herbs, different types of appliance similar to the effect of the intermaxillary class 2. For the reason, this is very important because one side fits all polyside, or the class 2 elastic is something like coffee for everybody. And this is a big problem. This is a patient. I treated this patient many years ago. This is a patient with a retrognatic mandible, with a retrognatic profile, with a class 2. You can see the problem of this patient is in a crossbite here. You can see here the crossbite, the shift to the mandible to the left, and you can see what is the treatment of this patient. We start first with night eye wires, and now it's time to stainless steel wires and the class 2 elastic. We are using a lot of class 2 elastic, combine the class 2 elastic with the curve of SP arch wire. The next step is to use class 2 elastic, between the canine and the molar. Next step is to combine orthostripping. We are using the orthostripping with class 2 elastics. Next step is to combine the orthostripping. You combine the orthostripping with the class 2 elastic and class 1 elastic to adjust the canine. Next step, the same 90 by 25 in the 90 by 25 in the upper, 19 by 25 in the upper, 70 by 25 in the lower stainless steel, and class 2 elastics and class 1 elastics in the canine. With this appliance, we correct the skeletal dental class 2, and also we correct the malocclusion, the class 2, and the deep bite, okay? Reduce the protrusion of the lower incisor. We get a good occlusion. We get a good, very nice arches with a very nice expansion, and a very nice smile. When you see the patient in the frontal view, it's a very nice smile. The mother is very, very, very happy with our treatment. But when we analyze the profile, this treatment is a complete disaster. This is a complete disaster, and I treated this patient. I treated this patient. Unfortunately, this is a complete disaster. Why? Because the main treatment of this patient is a dental-alveolar treatment. Why? Because the main effect of the intermaxillary class 2 elastics is the protrusion of the lower incisor and the dental-alveolar effect. You can see the difference between the N and B angle at the beginning of the treatment and the N and B angle at the end of the treatment. It's the same angle or even worse, this angle. You can see the protrusion of the lower incisor. You can see the intrusion of the upper incisor. And okay, we correct the molar relationship, but the correction is for the forward movement of the lower incisors. Unfortunately, you can see here the superposition with PowerPoint between the start and the end of X-rays. And unfortunately, you can see this. You can see how the lower incisor increased the protrusion and without growth of the mandible, because the upper incisor reduce the stop of the growing of the mandible. For this reason, it's very important to analyze this. According with Visara, when the mandibular growth is tending to grow the mandible anteriorly, the occlusion is provided with intermaxillary elastic of class 2, a force system to perpetuate the class 2 by moving the upper teeth forward and the lower teeth distal. This is like a posterior rotation of the occlusal plane and the posterior rotation of the dental-alveolar process. For this reason, this is very important. The class 2 in many cases produce the protrusion of the maxillary and even the retrusion of the mandible. For this reason, it's very, very important to understand this bisal circle. Okay, this is the class 2 elastic. In a lot of patients produce a lot of problem. And it's crazy because most of the techniques nowadays use only headgear and maybe class 2 elastics to correct this. For example, different techniques in the history of orthodontic don't use functional appliance. And in cases like in the MBT, that we're using functional appliance at the start of the treatment in the first phase, the first orthopedic phase. For this question, the question is, are we adapting the appliance to the malocclusion or the malocclusion treatment to our appliance? In my opinion, the main problem in the history of orthodontic is the adaptation of the malocclusion to the appliance. And this is a big problem. For this reason, Houston, we have a problem with the mandibular class 2. We have a very big problem, and we have a lot of mistakes because 90% of the treatment of the mandibular class 2 is with intermaxillary class 2 elastic. Most of my class 2 patients in Spain, I live in Spain, in the north of Spain, close to the border of Portugal in the north, and in my patients present, a lot of my patients present, maybe 80% of my patient with class 2 present maxillary dental-alveolar problem with molar problem and incisor problem, and mandibular basal bone problem. And unfortunately, most of the commercial techniques don't believe in functional appliance. Nowadays, yes. Why? Because now Invisalign try to move the mandible forward by means to put in the appliance something similar to a twin block. And now, yes, now it's very important, and it's possible to Invisalign to produce the growing of the mandible. Only the problem in our profession is a problem of money. And in the other part, some functional doctors, like the orthotropics, believe in miracles without evidence. Okay, without evidence. We have to combine. This is the two extremes of the orthodontic philosophies. No functional appliance, and in the other side is possible to do with functional appliance. In our patient, most of the mandibular class 2 are the result of the muscular imbalance. The worst appliance to treat this muscular imbalance is the fixed appliance, and the best appliance to treat it is the functional removal appliance. For this reason, it's very important. We have a lot of mistake when we are talking about the mandibular class 2. About the maxillary class 2, I think that we have a very huge agreement between the different orthodontic schools, but the problem is the mandibular class 2. Okay, the first problem is that we need a new classification because this malocclusion is completely different to this malocclusion or this malocclusion or this malocclusion or this malocclusion. This is a vertical malocclusion. This is a mandibular malocclusion. This is a maxillary malocclusion. This is a mandibular malocclusion in a growing patient. This is a retrognatic mandible with crowding. For this reason, it's very important a new classification, and the center of the diagnosis of the class 2 to select if the class 2 is a maxillary or mandibular problem is the nasolabial angle. A new class 2 malocclusion, everybody is okay with the idea of the dental class 2. The molar class 2, the canine class 2 is very easy to evaluate. It's more difficult to evaluate the component of the malocclusion for the reason, and the occlusion indicate the problem, and the face of the patient indicate, or the profile of the patient indicate how to treat the problem. In many cases, it's a little bit subjective and is in relationship with the fashion. In this patient, the main problem is the upper maxillary, the maxillary and the upper frontal teeth. In this patient, the main problem is the mandibular teeth. The class 2 malocclusion is very frequently in Caucasian. Depends of the different areas of the world. But maybe in Europe is about 20%. Between the Caucasian people is close to 20%. What is the academic classification of the class 2? Is a maxillary class 2, mandibular class 2, mixed class 2. I don't like this classification because it's like a mix apples and pears. I don't like this mix. Why? Because most of my patients present both class 2. Dentoalveolar maxillary class 2 and basal bone mandibular class 2. For the reason I would like to talk about the dentoalveolar problem, skeletal problem in the mandible, and in the mandible we divide the sagittal problem and the vertical problem. Okay, and the mix is dentoalveolar problem and skeletal basal problem. For the reason in the maxillary dentoalveolar problem, I prefer to treat the patient with the treatment of the anterior guide with different type of appliance, even with fixed appliance, the utility, the mulligan. For the problem of the first upper molar, we have the dentoalveolar distalization of the first upper molar, and we use for the dental distalization a lot of appliances, like the appliance by Dr. Carrier, headgear, pendulum appliance by Hilgers, different type of appliance by Wilson, distalizer, a lot of appliances. For the mandible, when the problem is a skeletal basal problem, it's possible to have a sagittal anterior-posterior problem or vertical problem. In the sagittal, it's a mandibular functional appliance. In the vertical, maxillary vertical control. For this type of malocclusion, is very important the vertical control of the maxillary. For this reason, I like to talk about the class 2 like a syndrome, like a medical syndrome. Syndrome is a set of medical signs and symptoms that are correlated with each other and often with a particular disease or disorder. For this reason, it's possible to have a light class 2 only with a molar or incisal problem, or a severe class 2. In a severe class 2, we have a maxillary problem, a mandible problem, a muscular problem, a chin problem, a TMG problem, a craniofacial problem. Okay, this is is like a syndrome. Okay, it's possible to have a molar problem, an anterior guy problem, a maxillary problem, a muscular problem, a mandibular body and ramus problem, a chin problem, and TNG problem, or a craniofacial or syndrome problem. For the reason, it's very important the evaluation of the patient, and the first step after the evaluation of the NLB and the maxillary mandible discrepancy is the evaluation of the nasolabial angle. Remember, the nasolabial angle is the lighthouse that guides our treatment. For this reason, the first level is the N, for the diagnosis. The first step is the NNB. The next step is the nasolabial angle. And the next step is the distance between the point A in the anterior part of the maxillary and the true vertical of the face. This is for the analysis of the sagittal or mandibular problem. For the vertical problem, the first step is to analyze the width appraisal. The width appraisal with two lines perpendicular to the occlusal plane. The upper line go to the A point, and the lower line goes to the B point. This is in relationship with the gonial angle and the maxillary mandibular length. This is the length between maxillary and the mandible. This is an absolute size of the length of the maxillary and the mandible, and the relationship between the anterior and posterior facial height. This is in relationship with the vertical problem. Okay, very important the correlation between N and B, and the width appraisal to the vertical problem, and the N and B and the nasolabial angle to adjust or to know what is the problem, maxillary or mandibular problem. For this reason, the nasolabial angle is very important. This you can see here the nasolabial angle. The most important part of the nasolabial angle is the lower part of this, the lower half of the is about more or less about 85 degrees. This is the nice nasolabial angle, and you can see how is the relationship between the A point, the inclination and the torque and the position of the upper incisor, and the nasolabial angle. The nasolabial angle is very important in the aesthetic of the face, and I think it's very important to evaluate of the nasolabial angle in the dentistry when you try to change the upper incisor in the position or try to rehabilitation the upper incisor. The nasolabial angle is very important because it's a very important point and very important angle in the aesthetic of the face. Remember this, the nasolabial angle is in relationship with the lips, okay, but it's in relationship with the upper incisor, the limit of the anterior maxillary limit, and is in relationship with the position, the torque, and inclination of the upper incisor. It's possible to change the nasolabial angle with our therapeutic decision. This is very interesting case, very old. I treated this patient many years ago. Ushia and Maria. And this is a twin, identical twin, with a nice identical twin, but Ushia broke the upper incisors, okay, 1 year after the treatment. The nasolabial angle is similar. The occlusion is practically very similar, the same class 1, 2, the same canine class 2, the same overjet, the same overbite, the same morphology of the gums, the attached gingiva, and I tried to decide to get down the upper incisor with headgear, the first, and the second with a Frenkel, with a class 2 Frenkel class 2. The result of the headgear and the Frenkel is very similar. Okay, at the end of the treatment is very similar, only a little bit different the hygienes for the fixed appliance, for the use of the fixed appliance. The frontal view is similar, but you can see the lateral view of the profile is completely different. In the first patient with the headgear, you can see the flat nasolabial angle, the posterior rotation of the mandible, and the increase of the length more or less of the lower third of the face. With the Frenkel, you can see the nasolabial angle is different, a little bit protrusion of the lower lip, only using headgear or only using the Frenkel to finish the treatment. You can see the difference between the nasolabial angle before and after the treatment, only 2 years of treatment. And for this reason, it's very important to analyze and to determine the type of treatment. Okay, what is the dentoalveolar maxillary class 2? Okay, the molar and incisal treatment. The first is the molar problem or the anterior guide problem. In this case, the patient present a problem at the level of the molar. It's very frequently in the class 2 malocclusion, the rotation and mesialization of the molar, and the anterior guide problem. Okay, for this reason, very important, analyze the first molar position, the first molar rotation, the incisal guide, the inclination of the second order bends, the shape and the arch form, the shape of the arch form and the dimension of the arch form, the curve of Spee and the curve of Monson and Wilson, and very important, analyze the torque of the molars and the premolars. Remember this, the malposition and rotation of the first upper molar is the etiology of a lot of malocclusions. Why? Because the first upper molar rotate around, around of the big palatal root, and for this reason produce a rotation, and with this rotation produce a problem with the space mesial to this molar. For this reason, we have to take a decision about the first step of the treatment. The step of the treatment in a lot of malocclusions, of class 2 malocclusion, the first step is the control of the upper molar. It's necessary the control of the upper molar. We are using in our technique, we are using the Wilson appliance. I like very much the Wilson appliance. We use the Wilson appliance because the Wilson appliance present a vertical insertion of the quahellis, the vertical insertion of the palatal bar, and with the vertical insertion is very easy. The control is very easy to insert because it's very easy to insert, and it's very easy to control the torque of the upper molars. I use a lot. I like very much the quahellis. The quahellis is an excellent appliance to produce expansion. At the same time, we use the quahellis to produce the rotation of the molars, okay, to produce the rotation of the molars. The pendulum appliance. The pendulum appliance is excellent to produce the rotation. The main problem is the inclination of the first upper molars. I have a presentation only talking about the different systems to distalize. In my recommendation, you have to use the most cheap. Don't use expensive appliance to distalize the molars. And I recommend to use a lot the headgear. The headgear is not nowadays in fashion. The patient and the mother maybe hate the use of the headgear, but this is an excellent appliance to distalize the molar and for the orthopedic effect of the first upper molar. Remember, the correct position of the first molar is very important. Remember the different keys of Andrews, and remember this, very important, the connection point number 3, the connection between the second premolar and the connection between the second premolar and the lower molar in the lower. Okay, I think it's very, very, very important to understand this. The proper position, the position of the second premolar sit in the lower first molar. For the reason in many patients, I prefer to adjust, like in this case, remove the brackets in the premolars, canines, and I put a headgear at the end of the treatment only for 3-4 months and use this elastic to distalize the second premolar and to adjust the second premolar. This is a point of contact very important. The second premolar sits in the first lower molar. Okay, remember that according with Andrews, the class 1 is not the cuspid in the sulcus. It's a little bit backward. Okay, in patient without extractions, like in this patient, it's very important that they adjust the class 1 after the loss of the temporary molars, and even in patient with extraction. This is a patient. In this patient, we extract the first upper and the lower premolar, and now we have to adjust the molar in a new class 1. Very important, the contact between the second premolar in relationship with the lower molar. I like very much this diagram from Professor Duran Born Arcs from University of Barcelona. I like very much. We modify a little bit, and remember, they analyze the molar class, the distance between the molar and the lateral incisor in the mouth, inside the mouth, the intraoral distance, or in the models, canine, the canine class, and the overjet. And I recommend this distance between the molar and the lateral incisor, the safe measurement is about 25 millimeters. Okay, for example, if the patient present class 2 in the right molar, class 1 in the left the position of the distance is okay, and overjet is okay. The patient only present a problem at the level of the upper molar, right? And we need to correct only the molar. But when the patient present a bilateral class 2, this distance is diminishing, okay, and the canine present a class 2 and the overjet is increased, the patient maybe need a combination of distillation of the molar and at the same time something to move forward the mandible. Maybe the patient present a dentoalveolar molar class 2 and mandibular class 2. I like very much this diagram. We use this diagram in relation with the distance between the molar and the vertical pterygoidea line is the h plus 3 millimeters. When is this distance is increased, we need to distalize the molar. When this distance is decreased, we need to distalize the molar, or even it's possible to produce the protrusion of the upper incisor. Okay, the evaluation of the class 2 is very interesting, like in this case, evaluate increase this, decrease this, or normal this. When the patient present a normal situation in this measurement and in the mesial measurement, the most frequent problem in this patient is a mandibular class. Okay, next time in the maxillary in the maxillary class 2, in many cases, when we produce with a quachelis, with a palatal bar, with the removal appliance, and expansion of the maxillary, the expansion of the maxillary produces the unlock of the mandible, the unlock of the malocclusion. And you can see for a proprioception, for the change of the proprioception and the expansion of the maxillary, the mandibular produce and forward movement, spontaneous forward movement. And I think it's very interesting because you can see with rapid maxillary expansion in a class 2, with the use of the quachelis, with the use with the quachelis and the utility, in many cases you can see this. The spontaneous movement is not the growth. The force is the spontaneous movement of the mandibular, of the mandible, and second, produce an spontaneous growth of the condyle and the rabus of the mandible. In other patient, we combine, for example, in patient with a very severe malocclusion, and the patient present a class 2 malocclusion for the rotation and mesialization of the upper molars, the first step is to use pendulum appliance. The main problem of the pendulum appliance is the inclination of the crown. For this reason, at the end of the use of the pendulum appliance, you need to use another type of appliance. I like very much the headgear with a coil spring in the back. The headgear from Rocky Mountain Orthodontic is a very nice. I like very much. And the patient used the headgear only for few months, maybe 6 months, or is okay. The objective of this headgear is to cross the force close to or above the center of the resistance of the upper molar. For example, this is a patient with a class 2. This is a very simple class 2. Excuse me, it's a very simple class 2. The main problem of this patient is the dental or molar class 2. We need to move backward the molar class 2 and to get a very good engage at the level of the canine and the premolars. In the other side, we are using a very simple biomechanics. We are using a mulligan biomechanics to produce the intrusion of the upper incisor. Only with a couple of wires from stainless steel, made of stainless steel, and the headgear is enough to treat this patient in the first phase of treatment. For the reason it's very important, remember this, overcorrection of the class 2. Remember the elephant. The elephant is the second upper premolar, and it's possible for the elephant to sit down in the lower molar. Okay. Okay, we are using cervical headgear, and it's very important to analyze. It's not this moment to analyze the use of the headgear, but it's very important to analyze the relationship of the force through the center of the resistance. The lower direction of pull produce extrusion as well as backward movement. Remember this. In many cases, the headgear is very useful when I need to correct the position of the upper incisor, and I like a posterior rotation of the mandible, for example, for the posterior rotation, or excuse me, the maxillary, to produce a posterior rotation of the mandible and to produce a correction of the deep bite. Okay, the expansion produces the mandibular unlock effect. In many cases, you can see how is the expansion of the maxillary produce the forward movement, the advancement of the mandible. You can see in this patient. In this patient, I use only headgear in the upper, and you can see how the mandible get forward. Okay, the relationship is very important to know. The relationship between the force through, above, or below the center of the resistance of the root, the relationship with the face boom, with the neck strap, and the neck strap of the molar effect, when the force crosses through the center of the resistance, when the force crosses above the center of the resistance, and when the force crosses below the center of the resistance. You can see the different effect only changing the length of the outboard, the length, and the type of relationship between the force and the center of the resistance. For the practical determination of the center of the resistance for my students, my master students, I use this type of wire. This is a piece of wire put inside of the mouth. Another part is outside of the mouth, and you can understand what is the ideal position of the outer bone and the neck strap to move the molar in mass or in a distal position. Okay, I think it's very practical and very easy to understand what is the relationship between the position of the molar and the force that we have produced. It's the maximum when you see a patient with very good cooperation, because in our office the main problem is the cooperation of the patient. But when you see a patient with very good cooperation like this patient, you can see the spectacular effect of the headgear. Headgear is an excellent appliance. It's not in fashion nowadays, but it is an excellent appliance. In this patient, only the use of the headgear in the first molars produce the rotation and distalization of the first molar, the second premolar, the first premolar, and both canines. For the reason, remember this is very important. It's very important to analyze the biomechanics inside of the tube of the molar, the biomechanics inside of the tube, and according with the biomechanics inside of the tube, we have different types of orthodontic tooth movement. Okay, according, for example, the ideal is this, when the force through to the center of the resistance, but this is different and this is different below. Another classical effect of the headgear, classical effect, the distalization of the upper molar, the distalization of the second and the first upper premolar, even the rotation of the canine thanks to the supracrestal fibers. The supracrestal fibers produce the rotation of the premolars and open a lot of space between premolars and the canine. Okay, you can see here, and it's an excellent system. This is a very old case. I treated this patient maybe 20 years ago. And in that time, I used it a lot, the headgear, because my master professor cannot recommend to use the headgear because the headgear is now, it's not in fashion, but it's an excellent appliance. Okay, this is a headgear. And when you are using the headgear, like in this patient, the headgear is possible to produce first expansion, second extrusion of the molar, and relative intrusion of the incisor, open the bite. Third, unlock of the malocclusion to the mandible move forward for the change of the proprioception at the level of the occlusion. And four, the bumper effect, because the inner bone or inner part of the appliance change the equilibrium of the muscles around the thumb corridor, eliminate the pressure of the cheeks, and produce a little bit of passive expansion. I think it's very interesting. Okay, I put now 2 or 3 brackets, very simple treatment. In the lower we put lingual arch and finish the treatment only with headgear. For the reason, the headgear is an excellent appliance, to simplify the treatment. Another patient, in this case, we use a very simple pendulum appliance. Distalize the molar with the pendulum appliance, and the most important treatment in this dental class 2 is to move the molar and the premolar backward, like in this case, to get the canine in a class 1. Now it's time to put the brackets in the upper and next in the lower. Put a crimpable hook between the lateral incisor and the canine in the right and in the left. Remember, I have talked about this in other webinars about our technique. We are using the synergy bracket. What is the advantages of the synergy bracket? It's very easy. When I put the ligature in the synergy bracket in the middle, only in the middle wings, the ligature doesn't contact with the wire. Okay, and the friction is close to 0. According with different researches in the American Journal of Orthodontic and Dentofacial Orthopedics, the different works from Professor Cordasco from the University of Catania, different from Messina University, from a lot of researches. When we ligate the synergy bracket in the middle, the friction is close to 0. Close to 0 is very similar, or even the value is less than the self-ligating brackets, or the most expensive self-ligating brackets. When we ligate the upper incisor in a figure in a conventional way, like here, we have a very good control of rotation and increase the friction. In this moment, it's important to increase the friction to control the torque tooth by tooth. For this reason, I like very much the use of the synergy, because it's a cheap bracket. It's very easy to use. It's like a conventional bracket, but we have the advantages to ligate tooth by tooth and to control the orthodontic tooth movement and the force tooth by tooth. Classical class 2 malocclusion, very simple. This is a patient with a molar class 2, only a molar class 2. A nice profile, and the main problem is the shift of the upper incisor to the left. Okay, what is the problem? The problem is this: the lack of space for the 23, for the upper left canine. The first step is distalize the molars. We use in this case the pendulum appliance. Remember the effect of the biomechanical effect of the pendulum appliance. About 20% is the protrusion of the upper incisor, 80% is the retrusion and the distalization of the molars. It was a very successful treatment, opened the space for the canine. Now with a coil spring, we put in the proper position, in the correct position, the upper midline, brackets in the upper and in the lower, and finish the treatment. What is the most important? Remember the position at the end of the treatment of the second upper premolar, with the connection between the occlusion between the second upper premolar and the lower molar. Okay, okay, and okay, very important. This is a very simple treatment. This is a very light class 2. This is the class 2 is a syndrome. Okay, this is the more easy case. Another patient with a class 1, skeletal class 1, but dental class 2. For a dental class 2, it's a complete dental class 2. What is the problem of this patient? It's a dentoalveolar problem at the level of the mandible. What is the best treatment? Functional appliance? No, forget functional appliance. This is a typical intermaxillary class 2 treatment. The patient needs class 2 elastic, and class 2 elastic. The correction of the deep bite is by means the use of 90 by 25 or 21 by 25 stainless steel with curve of SP, class 2 elastics. In this case, is in a second premolar, but the normal position is in the first molar. We are using very important. We are using ligate the scenery bracket in the middle, because in this part we need low friction, like a self-ligating bracket, like a diamond bracket or the self-ligating bracket. Okay, in this part we need low friction, but in the front teeth, in the upper incisors, we need increase the friction. Why? For the control of the torque. For this reason, in this patient, we ligate in a figure of 8. It's possible to ligate in a figure of 8 or ligate in a figure in a conventional way. With this idea, it's very clear, is with the scenery it's possible to combine the low friction with a high friction. If you have a self-ligating bracket like Damon, okay, it's a very good bracket. It's a good philosophy about the low friction. I don't like very much the over-expansion philosophy of Damon, but it's a very good bracket, and it's very good bracket to sliding the wire in the back. What is the problem with the Damon bracket? The problem of the Damon bracket is in the upper incisor, because when you are using a self-ligating bracket, you have a problem of a lack of torque, and you need torque, and you need friction to increase the friction and to increase the torque. And this is a problem when you are using a passive self-ligating bracket. The end of the treatment, the straightening. This is okay. The occlusion, okay. The occlusion is okay. The occlusion and the straightening. What is the straightening? Straightening is this. It's not over expansion. This is a straightening. Okay. We move only the crown. Don't move the root. Okay, another patient with a very high irregularity index, with a high problem, with a high class 2. In this case, the problem is the big, huge rotation of this molar, okay, the mesialization of the molar, okay, the lack of space here for the canine, and the shift of the upper midline to the right. What we analyze this, and this space is increased, this space is decreased. This is very useful, very easy. We need what? We need distalize the upper molar, but at the same time, we need to produce the protrusion of the lower molar. What is the situation of the mandible? The mandible is okay. The mandible is okay. The position of the mandible is okay. Here, the mandible is okay. I think it's very, very important to understand this. What is our treatment? Our treatment, it's possible to use a lot of appliance. I like very much my friend and excellent orthodontist Luis Carrier and the father Jose Pepe Carrier. It's possible to use a Carrier distalizer. It's possible to use the mini screws. Nowadays, I use a lot of mini screws in kids. I like very much to use mini screws in kids. And I recommend in this case, I use the classical pendulum appliance. The idea of the pendulum appliance is to move backward the molar, to move backward the molar. Remember, 20% is the protrusion of the incisor. In this case, it's a good solution. 80% is the distalization of the molars. I like very much to use this. This is a utility arch wire. I use the utility arch wire in this case, in 70 by 25, okay, 70 by 25 stainless steel, because my objective is to maintain the space between the molar and the incisor. Okay, okay. Now we use the loops. Okay, class 2 elastics to engage the case and the end of the treatment. Okay, okay, the class 2, very easy. The effect of the headgear of the pendulum appliance, we distalize, okay, distalize this and distalize the upper molars, okay. Now we put the canine in the proper position and it's okay. Okay, very interesting this. You can see now the midline is in the correct position, and you can see this treatment without extractions. Okay, another patient, very similar. We are talking now about the most popular treatment of the class 2. The most popular treatment is distalizing the molars, distalizing the molars and premolars, and the use of the mandibular or intermaxillary class 2 elastics. In this patient, we have a lack of space here for the canine. The midline is shift to this direction. What is the most simple treatment? The first, anchorage. Keys treatment, please. The first is a palatal bar, a simple palatal bar. The next step is to use a coil spring to open the space here to distalize the premolar, okay? and now adjust the occlusion. I think it's very interesting this, because it's very important the control of the first molars. A lot of techniques nowadays talking about that it's not very important the position of the first molar. The most important is to expand, and to expand, or is possible to produce the correct rotation and distalization of the upper first molar. In my opinion, it's not true. Okay, the first question is this. The distalization is a very simple treatment. The first step is the palatal bar. The next is to open the space between the lateral incisor and the first premolar with its sectional arch. Now we are using class 2 elastics, and the main problem of this patient is the gingival recession. Is very important to control the gingival recession, or to use a flap or a gingival treatment, or gingival plastic treatment for this canine. But unfortunately, we have a very good result without treatment. Okay, the nice smile of the patient, and the same, remember the patient before, the shift to the mandible, the upper midline to the right, and you can see the nice, okay, midline in relation with the upper lip, with the end, with the face. It's very important. Another patient with a crossbite. The main problem of this patient is a crossbite in the right. A shift to the mandible to the right. The first step, very simple. And my first step is to use a quachelis with elastic, with a crisscross elastic, to move a little bit the first lower molar to lingual. We use the Bridenstine steel, the use of the unilateral quachelis to produce the expansion of this molar, okay, to open the bite. And now we are using something very special for me, because I like very much this bypass arch wire. This is a mulligan, arch wire. It's made of in stainless steel, and in conventional stainless steel. It's possible to made of in Australian stainless steel, but if I use the conventional or edge-alloy, and I use this bypass arch wire by mulligan to produce the expansion, expansion of the molars. Okay, after the use of this mulligan, we put a crimpable hook here. We put a crimpable hook between the lateral incisor and the canine to adjust the elastic in class 1. This elastic, now we are using Bridenstine steel to adjust the occlusion and the end of the treatment. And this is very nice, the result, using only wires and brackets and the quachelis. Okay. In other cases, we have a problem with a class 2. The problem of this patient is an skeletal problem, but the main problem of the patient is a protrusion of the upper incisor, the Bolton discrepancy between the upper and the lower. You can see the B protrusion in class 2. In this case, the first step is to align the teeth, and we evaluate in the after the alignment of the upper and the lower incisor, we decide to extract. Why? Because you can see the anterior limit of the occlusion, and you can see the lower lip. If you see the lower lip with a lot of protrusion, we decide to extract the second premolars, the second upper and the lower premolar, with a medium anchorage in the upper with a palatal bar. We are using the crimpable hook. We put crimpable hook, this crimpable hook, the same. Okay, remember, We need in the canines, in the premolars, we need now low friction. For this reason, we ligate the canine and the premolars in the middle. When we ligate in the middle, the ligature doesn't contact with the wire. When we ligate the upper incisor in the shape of 8, okay, X, like in X, in this case, we increase a lot the friction. Maybe the friction here is close to 150 more or less grams. It's completely different to in the premolar or the canine, and the friction is close to 0. Okay, finish the treatment. Now we are using gunmetal T-loops. Gunmetal T-loops is possible to made of in gunmetal or in beta 3 titanium. Okay, and finish the case. When I have problems like in this patient with the delayed eruption of the second upper and the lower molars, in many cases we use this appliance like retention. This is a gunmetal clamps, okay? Okay, this is a gunmetal clamps, and with this gunmetal, this appliance move the molar to vestibular and move this upper molar to the palate. Okay, I think it's a very good result. You can see the result to use this type of appliance as a retention. Instead to use conventional retention, I use this type of appliance, like in this patient. The end of the treatment and the end of the treatment. Okay, another patient with a huge maxillary dental protrusion with a macrodontia of the upper incisor, Bolton discrepancy, overjet. In this case, with the overjet and space enough for the retrusion and for the intrusion of the upper incisor in maybe around 9-10 years old girl, I prefer to use the C modeler from Dr. Cervera from Spain. Is a silicone C modeler with a upper strap and with a high pull, and it's very good for the control of the upper incisor, to retract the upper incisor, even to produce a little bit intrusion of the upper incisor. We are going to close the bite. We are going to close the bite. We are going to close the bite with intermaxillary elastics, engage the occlusion, and you can see the patient just after the treatment without extractions, using first the headgear, or excuse me, the high pull with the Cervera C modeler, and next the use of our technique of straight wire low friction with the scenery bracket. Okay. Another possibility is to for the upper incisor protrusion is combine the C modeler from Cervera with our technique of I am going to talk in the future about this. Our eruption guys, okay, proprioception. Okay, the idea is very simple. The idea of the eruption guys is to produce to use aligners in kids. We are using the aligners in kids to engage and to conduct the eruption of the upper and the lower incisor to get the class 1 as soon as possible. The idea is very simple. The first phase of the treatment is with functional appliance or the classical orthodontic appliance in mixed dentition. Quagelis, the use of brackets and wires, with utility or Mulligan arch wires, the use of the Frankel or another type of appliance. In this, and the second is the name in Spain is guías eruptivas propioceptivas. The name is eruption guides, propioception guides. It's a polymeric guides for the eruption and the control of the inclined planes. Okay, you can see what is the objective. Our objective is very simple. You can see here the objective is this is the patient, okay, and now we put the proprioception guys. The proprioception guys, you can see the attachment, and we get the proprioception guys and put the occlusion in class 1. Okay, we are working with Alinea Den. Alinea Den is a Spanish company. It's a Spanish company from Malaga. From Malaga, the name is OrthoPlus. Now we are putting the attachment in the mixed dentition patient. And you can see here, very interesting, how the upper canine with our proprioception guys is get down and is putting the upper canine right in the left upper canine is putting in the correct occlusion. Okay, the proprioception occlusal proprioception change the position of the TMG and the position of the mandible and control the growth. For this reason, with the proprioception guys, is very easy. We control the eruption of the teeth, and thanks to the control of the eruption of the teeth, it's possible to control the growth of the mandible. For example, this is a patient with a severe class protrusion of the upper incisor, with a protrusion of the upper incisor. What is the first step? It's impossible to put in this patient, impossible to put an aligner. For the reason, the first step is to put the C modeler. We use the C modeler to retract the upper incisor to control the vertical growth of the mandible, and now inside of the C modeler we put our proprioception guys. We put our proprioception guys. For example, we decide to extract the first temporary molar, okay, and now you can see here the attachment, and you can see here the space to put here the premolar. You can see how the premolar, okay, now is in occlusion with this and the change of the occlusion of the patient. Okay, it's very, very, very interesting. This is a new idea. I think it's a little bit different to the Invisalign, because Invisalign trying to introduce the aligner at the start of the treatment of the kids, so it's okay. But our idea is very simple. Our idea is to combine the use of the functional appliance with aligners, the C modeler with aligners, or the use of a very simple 4 brackets in the upper, Quachelis, to use the first 4 brackets Quachelis, and at the end of the first phase of the treatment in the late mixed dentition, we use now this type of aligners to finish the occlusion and to avoid the second part of the treatment. Okay, the next question is about the mandibular class 2 treatment, the big mistake. Do you believe in genetic or in epigenetic? A big problem in a mandibular class 2 is not a TMG problem or the ramus growth problem of the body growth problem of the mandible, even the chin. The chin is a little bit different because the chin depends 100% of the genetic. Okay, but the muscular problem is a huge problem in this patient. In our patient, most of the mandibular class 2 are the result of the muscular imbalance. The worst appliance to treat this muscular imbalance between the lips, the cheeks, and the tongue is the fixed appliance. And the best appliance to treat it is the functional removal appliance. For this reason, in a lot of patients, what is the main problem? The main problem is this. The problem of the buccinator muscle, the orbicular muscle, the lips, the cheeks muscle, all this muscle produce the collapse of the arches and produce a lot of forces in the mandible and limit the growth of the mandible. Remember, please, to the Melvin-Moss hypothesis about the idea of the functional matrix. The most important is this. The most important is this. In the growth sites are not growth centers. Growth sites with a very big influence by the epigenetic. For the reason the epigenetic in the craniofacial growth, in the facial growth is more important than the genetic. And this is very important. Remember the idea of Moss about the muscle, the relationship between the shape and the function, about the relationship between the muscle and the bone, the relationship about the relationship between the tongue and the teeth. Okay, the muscle, the ligament, the activity of the muscle and the ligaments control a lot the growth of the bone, control the growth and the shape of the earth form of the position of the teeth. Do you believe only in genetic? Remember the class 3 in the Habsburg and Bourbon family in the Spanish kings? Or do you believe also in the epigenetic? In the hydrocephalia is a very good example for epigenetic. The block of the fourth ventricle in the brain produces a spectacular and huge growth of the deformation of the cranium. For this reason, in my opinion, the face is in relationship with the epigenetic. In many cases, it's very difficult, like in a Binder syndrome, in another relationship between different ideas. The hypothesis of Scott about the influence of the nasal septum in the growth of the mid face of the mid part of the face is very important. The only a problem at the level of the anterior nasal spine. A small problem here produces a huge effect in the growth of the cranium, in the growth of the mid face. For this reason, it's very important to understand the role of the tongue, the lips, and the cheek, and the growth of the mandible and the breast. In many cases, this muscle produces the block of the growth of the mandible. The tongue produces an open bite. The lips and the cheeks produce a change of the alveolar bone and the position of the upper and the lower stars. Remember, at the same time, when you put a functional appliance or you put something to move the mandible forward, in the long time, the temporal bone of the glenoidea fossa adapt to the protrusive function and produce in the inner part a lot of bone apposition. This is current in the history of medicine. We need to have a more close ideas in relationship with the medicine. Remember, this is very important. Orthodontic, I am a medical doctor, and orthodontic is between the medicine and dentistry. Orthodontic is not dentistry also. Orthodontic is in the middle of the medicine and the dentistry, because the orthodontists, we use a lot of new concept, a lot of new anatomical and physiological concepts from medical doctors. For this reason, we have to evaluate the ideas of between the relationship between the function and the bone, the occlusion, the bone, and the growing. The hypothesis of the functional matrix is very important. The role of the tongue, the role of the cheeks, the role of the upper airway, the role of the masseter muscle during the sleep. Okay, I think it's very important when you put a functional appliance like a Frankel. The Frankel use a lip pad in the lateral part and in the class 2 in the lower lip. You can change all the you can see how he move the lips, the tongue, the expression of the muscle, and I think it's very important. For the reason, it's possible to treat the mandibular class 2 according with a lot of the classical school. Only is possible to treat the mandibular class 2 with orthodontic surgery. Maybe today is possible with class 2, with Carrier, with the Forthus, micro implants, but I believe a lot in the use of functional appliance. I believe a lot in the use of functional appliance. This is the evolution of the functional appliance. In the 18th, a lot of researchers from McNamara conclude that the functional appliance works very well. Between 2000 and 2015, more or less, is how the functional appliance doesn't work, only produce dentoalveolar growth. Nowadays, is increase the use of functional appliance. Why? For two reasons. There are two reasons. Is an economical reason. The first reason is for the new digital orthodontic appliance, new digital orthodontic functional appliance. And the second is the idea of Invisalign and another companies of aligners to produce appliance to move forward the mandible to try to stimulate the growth of the mandible. Okay, only for the economical reason. It's possible. The classical idea is this. What is the classical idea? I have a class 2 like this. I put a functional appliance like this, and I try with the functional appliance to stimulate the condyle, the ramus, okay, this part of the mandible. After the use of 2 years, 3 years, a lot of time, okay, it's possible to get a very good growth of the condyle, of the cartilage of the condyle, even the glenoidea fossa, the ramus, and the body of the mandible. Okay, what is the problem of this? The time. We need a lot of time to treat this patient. And what is the big problem? The main problem is the patient, at most in my office, it's impossible to treat a patient for 3-4 years with a functional appliance. Impossible. The patient use the functional appliance in our philosophy only during 1 year maximum. Okay, what is the effect when you put if in this patient I put an activator many years ago? You can see the dramatic change of the position of the maxillary and the mandible. The real effect is very interesting. For example, this is my kids. I have 5 kids, and this is my youngest kid, Javier. This is a twin, okay? And you can see Javier before being born. You can see the retrusion of Javier, the retrognatic mandible of Javier, and you need to try to believe for the treatment of Javier with 3 years old with the retrognatic mandible, and the problem of Javier is genetic or epigenetic. Do you believe in the Meckel cartilage or belief in the role of the muscles in the class 2 malocclusion. If you believe in the Merkel cartiole, the treatment of Javier is an orthodontic surgery. For this reason, a lot of schools like Roth's school and other schools don't believe in the functional appliance to stimulate the growth of the mandible. Don't believe in the different appliance to unlock the malocclusion, to unlock the mandible, and to move the forward. And this is a problem because according with this school, the best treatment for Javier is about 18, 19, or 20 years old, and it's time to do an orthodontic surgery to move forward the mandible. But this is a huge problem because in many cases, the main problem is the relapse of the surgery, the relapse of the surgery for the powerful of the muscles of the chin, for the muscles of the orbicular oris, or the muscles of the buccinator muscle. I think it's very important to understand this. What is my opinion? My opinion is a lot of boundaries. You can see here Javier, and the muscle of Javier, the very strong muscle, very strong muscle in the lower lip. And for this reason, about 8 years old, we use from a very simple appliance, a very small and simple appliance. It's a Frenkel Class 2 appliance. I use the Frenkel Class 2 appliance only, without brackets, without quachelis, without nothing, using only during the night and at home and during the weekend. And you can see the dramatic change of the face and the occlusion of Javier. Using only a piece of acrylic with 2 or 3 wires with a very simple design, the dramatic change of the face. And this is the same in our patient with craniofacial syndromes in our medical orthodontic department in the University of Santiago de Compostela. In our Center for Craniofacial Research is the same. Functional appliance is something miraculous, is something spectacular in a lot of patients. You can see the change of Javier only using this simple appliance. For finishing, the mother, Monica, she is a very brave orthodontist with a very philosophy of tweed. She put brackets and wires and to get a nice class 1 and finish the treatment of Javier with a propioception eruption guides to engage the malocclusion. You can see the upper canine, okay, the upper canine in the correct position. It's very important to avoid this, avoid the canine in class 1, okay, and now you can see the proprioception guides to engage the canines in class 1, the end of the treatment, and you can see the nice result of Javier thanks to the use of Frenkel, brackets and wires, class 2 elastics, and incisor proprioception guides. But the most important treatment in Javier was the Frenkel appliance. For this reason, you can see the difference between Javier, and you can see the profile, the evolution of the profile of Javier, and it's a spectacular the end of the treatment, the correct position of the lower incisor, a little bit correct hypercorrection of the lower incisor, a very nice deep bite, the correction of the N and B, the muscles, okay. For the reason with Santiago Garcia Ferron, with in the lab, we design different types of functional appliance. Digital with Ortho Plus from Malaga with Jesus, and with Santi different acrylic, different design. The idea of this design is combine this appliance with fixed appliance at the same time. This is the different design. This is, for example, a mix between a Frankel and a Bimbler. Okay, it's a mix. For example, this is a typical patient with a class 2, division 1. The main problem of this patient is a muscular problem. For the reason, the main treatment of this patient is a muscular treatment. Okay, muscular problem, muscular treatment. We use the Frankel appliance. We use the Frankel appliance. Okay, we have now the Frankel appliance. Now it's time to put brackets and wires because we need now the engage of the malocclusion. We are using we are using the Frankel appliance to jump in the bite. Okay, jump in the bite, to jump in the bite. Forget to use the Frankel appliance to stimulate the growth of the condyle. Okay, forget, because it's take a lot of time. It's very easy. In our idea is very easy to jump in the bite with functional appliance. Maybe 6 months, 8 months is enough. And now it's time to engage in class 2 elastics. And we have a lot of time now with a new functional appliance. What is the new functional appliance? The natural occlusion of the patient. Okay, the end of the treatment of the patient. And I think it's very important. This is the summarize of the patient. In many cases, I use the remodeling a little bit. You can see remodeling a little bit the burn, the position of the incisor. Okay, remodeling a little bit this to move this canine in this direction and this canine in this direction. This is the idea of the proprioception guide, the digital or the digital proprioception guide. This is the same idea, okay? And the end of the treatment. The same, remember the same. We need here what? Need maximum friction. For the reason, engage or ligate the upper incisor in a figure of 8. In the back, here, ligate in the center, in the back, ligate in the center to diminishing the friction. Okay. More cases like this, functional appliance, only in 6 months, the result is spectacular, thanks only to the effect of one appliance. Only with one appliance is possible to change in 6 months. Now put brackets in the upper, wires, and the end of the treatment. Okay, I like very much to show the cases in my courses almost 5 years after retention. Okay, it's very important to see or to show the cases in a very years, a lot of years after the treatment. Okay. Another patient with a protrusion of the upper incisor, retrusion of the mandible, Frankel appliance. First, the effect of the Frankel. Next is to engage the occlusion with wires and brackets. Okay. And a very nice patient. Okay, I think it's the effect of the functional appliance, when you combine the functional appliance at the same time that the fixed appliance, is very nice. For this reason, is please forget the mistakes of the mandibular class 2 treatment. Forget to use only brackets, wires, and class 2 elastics. Okay, why is important? Obstructive sleep apnea. A lot of patients need to move forward the mandible, not the dental-alveolar manner. We need to move the body of the mandible. Okay, remember this, in many patients, we use this type of appliance to move forward the mandible, and the patient improve a lot the upper airway and improve the snoring. Okay, another patient come to my office because the main problem of this patient is an obstructive sleep apnea. Obstructive sleep apnea. Okay, present a very retrognatic mandible. I explain to the patients what is the problem, the huge problem. I explain to the patient, okay, to move forward the mandible. Okay, what is the problem of this patient? The main problem of this patient is the retrognatic mandible, the role of this muscle around the mandible. The upper airways, the first step of the patient is to use a bionature. We use a bionature to move forward the mandible and to increase the space for the lower molar, because we have a problem here with the lower molar, and I need the destruction of we need destruction of the lower molar. We combine we treat this crossbite by using a button, a metallic button in the upper and the lower, and a crisscross between the upper and the molar, the acrylic. Okay, the acrylic. And the second phase of the treatment is using a Frenkel appliance. Okay, the Frenkel appliance. We are using the Frenkel appliance, okay, to change the muscle. You can see the effect of the Frenkel appliance, okay, to distalize the molar a little bit, okay. This wire is very important to avoid the retrusion of the lower incisor, and it's very important, this part, to eliminate the pressure of the lower lip muscles. Okay, put brackets and wires in the upper, the end of the treatment, and the patient is not very good hygiene, but you can see the good effect after the treatment. The most important is this. The most important is the spectacular growth of the mandible. If you compare the spectacular growth of the mandible compared with the change of the maxillary. For this reason, it's very important to understand this. The same problem is with the dual bite, the mandibular lock, the muscular hyperactivity, the muscular pain, and I think a lot of patients with class 2 present a lot of problem with the subluxation or even dislocation. For this treatment, maxillary dental-alveolar problem, I recommend dental-alveolar distalization of the first molar. For the mandible, I recommend the use of the mandibular and vertical. Okay, and this is step by step, our protocol for the use of the headgear or class 2 elastics, or the use of functional appliance, or the use of the toucher or micro implants, according with the age, with the problem severity, and with the compliance aspect of the patient. For this reason, for our first decision is about the use of functional appliance of surgery in a lot of patients. at the level of teeth distalization appliance of the use of the intermaxillary elastics. For this reason, remember this. The main problem is this. Are we adapting the appliance to the malocclusion or the malocclusion treatment to our appliance? Even in cases like in MBT, that Dr. Trevisin, excellent and outstanding orthodontist from Brazil, used the functional appliance. And I think, I don't know nowadays, but I think that functional appliance, a lot of doctors who use functional appliance, use the first phase of functional appliance and a second phase with orthodontic or with the fixed appliance. What is the problem? The problem is this. The main problem is the puberal spurt. The puberal spurt is close to 14 years old in the boys. For this reason, it's very important to understand two or three concepts to analyze the main problem of the mandibular cluster. It's the same, the use of fixed appliance that the use of functional appliance, okay? The first problem is this. We don't have enough researches, enough evidence in a lot of part of orthodontic treatment. For example, it is. For the reason I like very much to talk about two concepts. The first concept is the dento-alveolar pool concept. The second concept is a very old concept from Angle, 1 century, more than 1 century ago. And the second concept is about the jumping bite or jumping bite. The first concept is a dento-alveolar pool. In many cases, we need to move the lower incisor, like in this case, we need to move, we need to move the lower dento-alveolar process, we need to move forward to correct, in this case, class 2, and dental class 2. We use for this, the best appliance for this is class 2 elastics. For example, this is a patient with a severe class 2 in the right and a perfect class 2 in the left. The shift to the mandible is to the right, not the mandible, the dento-alveolar mandibular process, not the mandible, is shift to the right. Okay, we control the upper molar, the symmetry of the upper molar, the symmetry of the upper midline with the face. And now it's time to use the headgear. We use the headgear to correct in Quachelis. Quachelis, I cut the arms to use the Quachelis like for the rotation of the molars. Now the utility. And now the main treatment is comprehend the use of thick stainless steel arch wires in the upper and the lower, and the class 2 elastics. Class 2 elastics. This is the idea. This is the dento-alveolar pull. The dento-alveolar pull is to move the teeth inside of the channel of the mandible. Okay, for stripping, engage the right part, and finish the treatment. Okay, this is the dento-alveolar pull. The main problem of this patient is a dento-alveolar problem. For the reason, the main solution is a dento-alveolar solution, is a unilateral dento-alveolar solution. For this reason, you can see the nice view of the patient, and the patient is a dental class 2. Now is a dental class 1, but the patient presented in the past a skeletal dental class 1 or a little maxillary class 2. The main effect of the main appliance, or the most effective appliance to produce this dento-alveolar pool, is the Forsus, the BL, the Herbs. A lot of appliances produce this dento-alveolar pool. What is jumping the bite? Jumping the bite is different. Jumping the bite was invented by Angle more than 1 century ago. For the reason, according with Angle, the main treatment of the class 2 is not the distalization of the molar. The main treatment is the something like wires or elastics in years after, to correct the class 2, to move forward the mandible. For this reason, Angle talk about the distal occlusion. The main problem is the distal occlusion of the mandible. For this reason, design this type of appliance, very similar to this type of appliance, design this type of appliance with wires to try to the patient with a severe retrusion of the mandible to move forward the mandible. Okay, in even we recommend the maxillary expansion. For example, Ricketts, the Robert Ricketts recommend to use the Quagelis for the maxillary expansion and to produce the mandibular unlock and to move forward the mandible. What is our idea? It's very simple. This is my doctoral thesis. We researched with Professor Suarez Núñez, was my father, and with another professor from University of Santiago de Compostela, professor, about the mesencephalic nucleus of the fifth cranial nerve. This is a weird research in rats and in guinea pigs. What is the role? The proprioception produces in the central nervous system a control of the nucleus of the motor nucleus, like the pterygoidea muscle. This produces a new mandibular position, and this circle control the position of the mandible. The mistake is, the most important is the TMG, and second, the growth of the mandible. This is a very huge mistake. The first step is the occlusion. Occlusion, according with Petrovic, the occlusion is the peripheric comparator, and the peripheric comparator control the position of the mandible, and the control of the position of the mandible control the position of the condyle, and the control of the position of the condyle control the growth of the condyle, the ramus, and the body of the mandible. For this reason, the director is the central nervous system, and the workers are the dento-alveolar process. Okay, for this reason, we use at the same time fixed appliance and functional appliance. Why? Because the patient hates long treatment. Nowadays, we combine the functional appliance with aligners, but in the classical treatment in our office, we combine functional appliance and fixed appliance. Okay, remember that the sagittal change is the result of the vertical changes. For this reason, in many patients like this, we change with functional appliance the position of the mandible, and you can see how is the growth of the mandible. Thanks to the basal bone, another mistake. Thanks to the TMG growth, another mistake. Thanks to the ramus and body growth, another mistake. The most important is the dento-alveolar growth. This part and this part, this part and this part. This part is very important in the growth of the mandible. First is the increase of the vertical dimension, and second, the growth of the mandible. For this reason, it's very important to divide what is the idea of the intermaxillary elastics or the use of functional appliance. Okay, I am professor, and my objective is to explain to my students my concept. And it's very important to understand this because my role as professor is comprehend to explain to my students the ideas and what is the most important difference between dentistry and orthodontic is the same like dentistry and medicine. Is in dentistry is very important the hand, how to do in medicine, in orthodontic, it's very important to thinking, to have a lot of ideas. Why? Because dentistry is the diagnosis in dentistry is very, very small. The diagnosis in orthodontic or the diagnosis in medicines is very huge. Okay, for this reason, you can see this. This is a patient. Imagine that the mandible is the train and the teeth are these cars. Okay, in this case, we need to move the car because the maxillary is in a correct position. For this reason, we need to move the mandible to get the class 1. Okay, okay, we move the train. This is the mandible. Move the train, but don't move the car. Okay, another again. We need to move the train. When we move the train, move the cars. Okay, this is a typical case that we are using. This is the cars, the teeth. We are using the teeth to we are using a mulligan archwire, excuse me, utility archwire to align the teeth, but we need to move the train. I move the train with a functional appliance. Okay, this is another different situation. This is a light or medium skeletal class 2. This is for example, an adult, and I need to correct the dental class 2 with the protrusion, with the pull, with the dentoalveolar pull of the lower incisor or the lower teeth. Okay, what is the best appliance to move the cars? We need to move the cars. We need to move the cars, not move the train. What is the best appliance to move the car? Class 2 elastics. For this reason, the class 2 elastics. For this reason, it's very important to divide almost in your mind. I think it's very important to understand the wonderful orthodontic word if you have very good concepts. Okay, for the reason if you need to move functional, if you need to move the mandible, you need to move the mandible with functional appliance. If you are using class 2 elastic is to the dentoalveolar. Okay, okay, and okay. Functional appliance or class 2 elastic functional appliance. What is the best time to start in time for the early class 2? I recommend the famous 2004 article from Camilla Tulloch and William Profit about the two phases randomized clinical trial of early class 2 treatment. Divide in a first group without treatment, second group with a rest, and a third group with headgear. After a rest period of this patient, remember the patient is a group of patients with overjet more or less about 7 7 millimeters or more. And after the rest period, after the first phase of the treatment, we mix all the treatment, and 4 doctors start the treatment in the second phase. At the end of the treatment, what is the main conclusion? The first is no less treated time, no less extractions, no less surgery. And according with other studies, the main problem of the first phase of treatment in this patient is the boarding patient and boarding parents. For this reason, it's very important to understand this no worth it. The first phase of treatment in class 2 malocclusion, maybe except for psychological reasons in the school, or even for the risk of broke the upper incisor. For this reason, what is our objective in our philosophy of digital orthodontic multi-technique and the strike wire low friction technique? What is our objective? Is to combine functional fixes or microimplants or distalizing appliance at the same time. For this reason, it's very important a case like this. What is our treatment? The first step, align the teeth and even increase the overjet. Why? Because we need overjet to move the mandible forward. The next step, to use a functional appliance at the same time that we are using the fixed appliance and the functional appliance. Normally, in our office, the patient depends of the age of the patient, but use the functional appliance at home and during the night, and fixed appliance 24 hours a day. Okay, use the functional appliance during the night, and using the functional appliance to improve normally the growth of the mandible, and we are using the brackets and wires to align the teeth, and also we are using class 2 elastics to engage. We have to move in many cases the train and the cars at the same time. It's very important the pubertal growth spurt. Like in this patient, this is a patient started treatment around 11 years old, put a functional appliance combined with a hot gear to control the molars, to distalize a little bit the molars, because in many cases we use both appliance. And you can see the dramatic effect of the functional appliance. We are finishing the case with a class 3 elastics. Okay, in many cases it's spectacular the use of functional appliance. Like in this case, we are finishing the case with class 2, with class 3 elastics for the overcorrection of the malocclusion. Okay, the end of the patient, and the end of the patient. I like very much, please finish the mandibular class 2 treatment with a correct position according with according with the classical orthodontic about the correct position of the lower incisor in 95 more or less degrees respect to the mandibular plane. It's very, very important, this concept in the classical. I hate when I am going to see people from Damon or people from self-ligating miraculous brackets and finish the treatment with the lower incisor in this position, especially in the class 2. Please, it's not possible to do this, please. It's very important. You can see in the patient the growth of the mandible, okay, the growth of the mandible and the patient, okay. This is my elder son, David. My elder son, David, he is now a very famous YouTuber and film director, and start the treatment with, you can see the class 2, division 1, 10 years old, and we start the treatment just in time, close to 13 years old, just in time. I start the treatment with a functional appliance and a headgear, a cervical headgear for the control of the molar. What is the objective of the first phase of the treatment? The objective with the functional appliance is to stimulate the growth of the mandible. Forget. The first objective is to jump in the bite, to put the mandible in a false class 1. Oh, this is a risk for the dual bite. No problem. Okay, because maybe it's possible the dual bite in a few percentage of the patient. But the normal situation is you have a lot of time because you have a new functional appliance. What is the new functional appliance in David? Is this the new functional appliance in David is the proper occlusion. Okay, the dento-alveolar pool. After the dental pool, we use the thermalloy 70 by 25, crimpable hook, stainless steel 90 by 25, stainless steel in the lower 70 by 25, and for finishing, beta 3 titanium 90 by 25 in the upper and in the lower with class 2 elastic. The end of the treatment with overcorrection, the follow-up of David, the most follow-up continues with the follow-up, and you can see 40 years after at the end of the retention period, only using in the lower the wire, and in the upper don't use nothing. Okay, this is the 14 years after retention, the end of the retention. For the reason is very, very important. And I like very much to show my kids because I don't like to show in spectacular cases of my office. No, I have a lot of cases like this, but I like to show you twins. I like to show you brothers. I like to show you my kids too, because this is the normal treatment in and the normal result in our office. Nowadays, it's very interesting the twin block digital, okay, the mandibular class 2. I think it's very, very interesting. This is thanks to the OrthoPlus research department. We are the director of the OrthoPlus department in Malaga, Spain, close to Marbella. I recommend to visit this lab. Maybe it's the biggest lab, orthodontic digital lab in Europe, and I recommend to visit because this is something spectacular. And we are working now in a lot of new simple things. Okay. For example, the use of the twin block. Okay, I like very much the use of the twin block. This is a conventional twin block. Okay, in patient, we use the hybrid twin block by Clark. We combine the twin block with the brackets and wires. Even we use magnets. In many cases, we use magnets in the same twin block, for example, to control the vertical growth of the patient. Okay, this is patient with a class 2. The main problem of the patient is the collapse of the mandible, or the collapse of the mandible. You can see here the scissor bite, okay, the retrusion of the mandible, and this is the first step is the use of the twin block to move forward the mandible. Okay, and you can see the result, the very nice result using the twin block and using a little bit brackets and wires only for the end of adjust the occlusion. In cases like this, put the retention in the lower, but in the splint, I put a piece of acrylic to produce an overcorrection of the bite because the patient, as you can see, present a little bit a retrusion of the mandible, and for this reason. Okay. Another patient, the first step of this patient is the first step of this patient is distalize the molar. Next step is this, to with a utility, with a Mulligan arch wire to correct the deep bite, brackets in the upper and in the lower, as twin block. Okay, put it in block. The classical concept is to put the team block for a 100% to the TMG growing. Forget this, okay? The ligament position is the first. We put this is the malocclusion. The first step is to increase the overjet. It's like in a surgery. We need to increase the overjet to move forward the mandible. It's impossible to correct, to get a very good or a very nice face without increase the overjet, because we need forward movement of the mandible. Okay, the evolution, a new periodontal proprioception, and now we are moving first. Remember the train, and now it's time to moving the class 2, to moving the teeth. For the reason we are using class 2 elastics. Okay, the end of the treatment, and this is we finish the treatment very early, and I prefer in this case combine the permanent retention, in this case with a wire in the back of the lower incisor, with the twin block. Okay, the evolution of the occlusion of the patient. Okay, another patient with a severe malocclusion. Okay, protrusion of the right incisor. Okay, when you analyze in a correct head position, you can see the nasolabial angle is more or less okay. Okay, we analyze the incisal guide of the patient, analyze the nasolabial angle, the overjet, the overbite, the lower incisal with in relation with the occlusal plane, the upper incisor to the vertical, true vertical, is more or less 4 millimeters. Upper incisor inclination with the horizontal, lower lip, interincisal angle, and we analyze very, very important, the design of the smile. We design the smile by means of the first step is very important, the cephalometric analysis. Cephalometric analysis for the smile design. Okay, the next step, we put the upper incisor in the proper position. Next step, interincisal angle. We need to move forward the lower incisor, and we need growth. We need growth of the mandible to get a very good incisor position. For the smile design, we need uncontrolled inclination of the upper incisor. In the lower, we need mandibular growth without incisal movement. Where we have to move molars, to distalize the molars, to produce protrusion of the incisor, we need to move the mandible. Okay, we have to analyze all of these elements, and we have, this is the treatment, okay, maxillary expansion, incisal guide, mandibular unlock, jumping the bite, use of functional appliance, second, jumping the bite with appliance, and the use of the different phases with a straight wire low friction. Okay, we are using a Quahelis for the incisal guide bypass arch wires, Frenkel, Beamler, and twin block for functional appliance. We use the Quagelis, the Beamler appliance, or Bionature, excuse me, and you can see the result. Very important, the mandibular catch up is very important too in this patient. The end of the treatment, the nice profile and mandible of the treatment, the nice cephalometric of the treatment of the patient at the end of the treatment, and you can see the growth of the mandible thanks to the use of the functional appliance. Okay, thanks to the functional appliance. And you can see the patient 3 years after the treatment with a follow-up with a very nice occlusion, with a very nice function and disocclusion. Okay, and for this reason, it's not possible to guarantee the result, but it's in many cases, in 90% of the cases, this type of the treatment with a very good diagnosis, because the problem is of the class 2 is the diagnosis. It's very important, the diagnosis. With a very good diagnosis and with a very good growth, is possible to treat very successful a lot of patients. This patient, you can see the ears of the patient, the face of the patient, the nose of the patient, the oral reading of the patient, the problem of the nasolabial angle of the patient, the upper lip. I need expansion. What is the best appliance to produce expansion in this patient? The most effective appliance for the dental expansion, in my opinion, is the Quagelis. It's very easy, it's cheap, and it's very simple to use, and it's like a multi-purpose to use the Quagelis. What is the best treatment to control the upper incisor at the same time to control the distance between the molar and the incisor? The utility arch. The utility arch is very easy to use, is very fantastic. I need to control the thumb corridor. I need to control the lips. I need to control the tongue. I need to control the cheeks. I can use the functional appliance at the same time that the fixed appliance, only at home and during the night. Okay, finish with the class 2 elastics. Remember, it's time to move the cars. It's time to move the cars with intermaxillary elastics. And you can see the result of the patient. I think it's very, very, very nice, the result. It's possible to get a very good occlusion only with wires and brackets. It's possible, but I prefer to combine with functional appliance, because functional appliance in combination with the brackets and wires produce, and class 2 elastic produce a synergist effect, and it's very nice for the health of the patient. Another patient, what is the problem of this patient? The main problem for the parents is the lack of a central incisor. The main problem for me is the retrusion of the mandible. It's completely different. You can see the mandibular class 2. What is the treatment? The treatment is open the space, okay, the eruption of the central incisor. Thanks to the scenery, we ligate in the center. When we ligate in the center, the ligature doesn't contact with the wire and the friction is close to zero. If we are using thermal wires very, very, very light, 15, 16, 14, the forces are the most physiological forces. Okay, combine in this moment with a special Frenkel. We design a special Frenkel to combine with fixed appliance. Now we are using the Frenkel with wires and class 2 elastics to engage the occlusion. Now we are using class 2 and now class 1 with beta 3 titanium in the upper for the occlusion. The end of the treatment, and the patient years, and the patient with a very good, not very good highness of the patient, okay, but a very nice occlusion years after the treatment. For the reason is that the same patient with a very severe gingival smile, we combine with the intrusion of the upper incisor with the vertical growth of the patient. Now we are using intermaxillary elastics and the end of the treatment with a good occlusion. Another patient with a very severe retrusion of the mandible, a very huge collapse, crowding in the lower, overjet, collapse, mandibular collapse, and a very, 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 very difficult case. This is a very divergent patient, overjet, mixed protrusion of the maxillary with a very flat and not very good nasolabial angle, protrusion of the lower lip. Maybe it's a surgical case, but we decide to treat the patient with orthodontic, with functional appliance, and without extractions. We combine the use of the first step was our mix between the Frenkel and Bimbler with headgear to distalize the molars. With the Frenkel and with this part of Frenkel Bimbler, we expand the maxillary. Now you can see the unlock of the malocclusion, stripping, and the patient years after treatment with a very good occlusion. The patient more years after treatment with a very nice occlusion, and the patient more years after treatment with a very good and stable occlusion. You can see the difference between 11, 14, and 19 years of age. You can see the effect of the functional appliance between 11 and 14 years of age. During this time, the patient used a lot the functional appliance to move forward the mandible. Another patient with a severe class 1, the main problem of this patient is 100% of mandibular class 2. The main problem of this patient is the mandibular class 2 and the rotation of the upper molars. The rotation of the upper molars and a little bit lack of space for the canines. It's a divergent patient with tendency to posterior rotation of the mandible, inclination of the upper incisor, and we need to stimulate the growth of the mandible. This is the most important. The first step is to use a Frenkel appliance. You can see here, after the use of the Frenkel appliance, you can see here the space between the distal to the canine, and now it's time to put brackets in the upper and in the lower, and class 2 elastics. Now it's time, remember, to move the train. Now it's time to move the cars. The end of the treatment, the follow-up with a little bit relapse in the upper. But the most important of this patient is the very, very nice change of the profile and the very nice change of the shape and the growth of the mandible. Okay, you can see the A point, the Change at the level of the point or upper incisor is a minimum change, but you can see the effect of the functional appliance and the combination between functional appliance and fixed appliance in the mandibular, the growth of the mandible, the growth of the soft tissues. Even when you are talking about the problem of the sleep apnea. Sleep apnea is very important in this patient. How increase the upper airways thanks to the use of functional appliance to move forward the mandible or almost to unlock the malocclusion. Another patient, the main problem of this patient, according for the mother, is only one problem: is this incisor. Only the problem is the incisor. What is the idea of our treatment? The idea of our treatment, this is the main problem, the nasolabial angle, but the main problem of this patient, the huge problem of this patient, is the retrognatic mandible, okay, the collapse in this area, okay, and we need to stimulate the growth of the mandible. At the same time, we need to control the premaxillary. Okay, the first step, increase the overjet. Please forget to move this incisor backward, because the most important in this patient is the face. For this reason, we put 4 brackets in the upper, 4 brackets in the upper. Okay, control the vertical dimension with the twin block with a very huge acrylic in the back, and at the same time we are using a headgear to control the molars and to put the molars backward. In this moment, the most important is to move the train forward. Next, now it's time to move the card. It's time to move the teeth. For this reason, we ligate with intermaxillary elastics, and the main problem now is the control of the friction. Control of the friction of the 4 incisor. For this reason, ligate the upper incisor in a figure of 8 to increase the friction and to increase the control of the torque. Okay, an excellent occlusion at the end of the treatment and a nice smile of the patient. For this reason, please forget to treat all the mandibular class 2 with elastics. Why? Because if you are using elastic and produce the protrusion of the lower incisor, the mandible growth in this direction, okay? And the risk is that, remember the case at the start of the webinar, the risk is at the end of the treatment to have the same face or worse and the same N and B. Please forget to start to use only class 2 elastic. Forget this, please. In many cases, it's possible to treat a patient without functional appliance with bite planes. Yes, I recommend the Chris Chang courses. I like very much the use of for Chris Chang, Dr. Chris Chang from Damon Philosophy, about the use of biplane. But I prefer to use I prefer to use functional appliance in the style of twin block in dolichocephalo patient, or the use of functional appliance like similar to the Frankel appliance when the problem of the patient is the orbicular oris, the muscle of the cheek, the muscle of the lips, or the muscle around the thummus corridor. This is a patient with a class 2 growing, deep bite, retrusion of the mandible. You can see the profile of the patient. And in this patient, I use the aesthetic brackets and thick stainless steel wires, white coated in white with white. Okay, and you can see using bite blocks in the posterior part of the upper incisor, and a lot of class 2 is possible to get a very good results. In this case, at the end of the treatment, we have a problem with the upper incisor, with a relapse, with a little bit relapse of this incisor. We use this as the retainer, cut the retainer, put a couple of button and elastic change to retract the incisor. What is the advantages of this treatment? With the bite block, is possible with the bite block to increase the vertical dimension of the patient without functional appliance. Okay, the main problem is to put the bite block in the lingual part of the incisors and class 2. Okay, and you can see in this patient the dramatic change of the patient, 19 years old, 21 years old, and you can see the spectacular growth of the mandible, in this case, without functional treatment. For the reason it's very important to analyze the class 2, is the diagnosis is very important, and please forget to use only class 2 elastics or appliance to distalize the molars in the mandibular class 2. And I think it's very good the combination now with the new digital functional appliance and the new aligners with the philosophy of to move forward the mandible. It's very nice to get a very good solution for the class 2. Thank you very much. Thank you. Thank you very much.